I'm RCOG and I work here in the Patient and Public Involvement team. Tonight I'm joined by 3 women who have a wealth of knowledge around all things pelvic floor health related, Myra, Elaine and Ali. So I'll get you to all introduce yourselves.
I'm Myra Robson. I'm an NHS physiotherapist in pelvic health in South London, and I'm also the physio behind Squeezy app.
I'm Elaine Miller. I'm a physiotherapist based in Edinburgh, and I wrote a comedy show about pelvic floors called Gusset Grippers, which seemed like a great idea at the time, and did fine at the Fringe, and we're now looking at whether you can use humour as a health promotion tool.
So I'm Alison Wright. I'm one of the vice presidents of this college, and I'm a consultant obstetrician and gynaecologist with a clinical interest in the pelvic floor.
And of course, Myra and Elaine, you're 2/3 of the fantastic PelvicRoar collaboration. Can you just tell us a little bit about that?
So PelvicRoar is a group run by Elaine, Emma Brockwell and myself, all pelvic health physiotherapists, who came together because we were attending parliamentary meetings about postnatal physiotherapy care, and we didn't realise that different meetings were happening around the same topic. So around about a year ago, we joined up to lead collaboration in pelvic health campaigning and to bring together expert patients, product companies, professionals and so on, and create one voice.
Fantastic. And I know not everyone watching may be aware of the role of a women's health physio. Can you tell us a little bit about the fantastic work you do?
So we tend to call ourselves pelvic health physiotherapy. That's the word we're going towards, because we do treat men and their pelvic health issues as well, although it is less common than women for reasons that Elaine no doubt will explain shortly. And we will treat people with urinary and fecal dysfunction, particularly incontinence, probably the most common condition that we treat. We will treat obstructive disorders such as constipation, we'll treat pelvic organ prolapse, sexual dysfunction, vaginismus, persistent pelvic pain, also pregnancy-related pelvic floor symptoms and musculoskeletal systems. And we can also advise on safe return to exercise, running, etc. postnatally.
Great. And Ellie, can you tell us a bit about the work that you do and your fellow obstetricians and gynecologists to support women around pelvic floor health and working with women's health physios?
Yeah, so we as obstetricians and gynecologists are obviously very keen to work closely with pelvic health physiotherapists. I think it's fair to say that there are not enough of you. Wouldn't you agree? So, you know, in my experience, it's been great working in a multidisciplinary team with physiotherapists. As I say, we're keen to have more input, we're keen to work more closely together. Particularly, I think, because of the prevention that physios can be involved, we're really keen to support physiotherapists being involved when there aren't problems in terms of pelvic floor guidance, but also earlier on when there are problems, because sometimes by the time women get to see us, things have got quite far down the line.
Yeah.
So I don't know what you think about that.
No, totally agree, yeah. and we're really keen to encourage the physios to come out of clinics so that we're communicating better within the multidisciplinary team, because I think often physiotherapists have got long waiting lists, so they're busy dealing with the women, so trying to get time to do further outreach is a real challenge within the NHS and within clinical practice. So that's one of the things that we're really keen on, and getting as many people that work with women, not just clinicians, but also looking at instructors, Pilates teachers, fitness professionals, because the women aren't coming to clinic, they're not coming to see us at all as a first step. There's some data that shows that only about a quarter of women will come to clinic at all, will mention to their GP. So most women are looking for information online, or else they're going to Pilates for help. So if we can work with those professionals and have like a mutual and reciprocal referral system going on, that could be really helpful.
Yeah, absolutely.
And it seems like pelvic floor health is still very much a taboo. We know you use humour as a way of engaging women around this topic. Are you able to tell us a bit about the pelvic floor, what it is, what it does?
I can, yes. I have brought one with me. I've brought 2 with me, but I'll show you one. And unfortunately, this isn't my best pelvis. It's been attacked by children, so it's sort of held together with bits of back, which is unfortunate. So I'm hoping that yours is in a better state. So pelvis, and the red bits are muscles, and the blue bits are ligaments, and the pink bits should be familiar. You're either sitting in a vulva or you maybe came out of one. and had a little look in the way by. And the job of the pelvic floor is does exactly what it says in the tin. It provides a floor for your pelvis. So it's one of its functions is to hold your organs in place, and it resists the forces that are coming from above if you laugh or cough or sneeze, and the forces that are coming from below. So if you're running, there's 3 times your body weight and impact rattling up your leg into your pelvic floor, which is why people sometimes have a problem with impact exercise. So sometimes women are okay if they're running for a bus, but if they're running park run or 10k or marathons, then they start to leak because the muscles are getting tired. And they've also got an important role in your sexual function. So an orgasm is in part a flickering contraction of your pelvic floor, and if you find your orgasm really worth bothering with, then it's good to know that when women start doing some pelvic floor rehab, often that's one of the first things that they notice an improvement in.
Always a reason to see women's health physio.
I think it's a motivating factor, and because adherence with pelvic floor exercises is the problem. But if you know that you can have a minute of fanny gallops, I find that then women suddenly have time to do their exercises. It's very interesting. Somebody should do a study into it.
And we've just had a question in, can women anywhere ask to be referred to a women's health physio? Is that something?
Yes, absolutely. So there are around about 800 specialist pelvic health physios in the UK that we're aware of, and that's a very small number. But there are physiotherapists in the NHS around the UK and also working privately, and some physios can accept self-referrals as well. So do go and speak to your GP, and the professional body POGP can find out details of pelvic health for you. And on the Squeezy app website shortly will be a directory of pelvic health physios as well.
In Edinburgh, if you Google continence services, it will come up with the NHS links. It's just a direct phone number that you would phone yourself. I think a lot of areas have got that now on the local websites. Yeah.
I think it's worth mentioning as well that physiotherapy and postnatal physio, particularly, isn't it? It's mentioned in the long-term plan. But we were really happy about that, because that does mean that it's going to keep on the agenda and raise awareness with women as well as with their doctors, hopefully.
Yeah, one of the problems is trying to get hold of women postnatally, because if they're in a 6-hour discharge, they're having their baby and they're out quite quickly, actually physically seeing them in the time that they're in the ward can be a challenge. And even if they're in for a while, if the baby's in special care unit or the woman's seeing the lactation specialist and they've got visitors, it can be quite hard to catch hold of them. So it's one thing that we would be really keen on seeing is trying to pick women up postnatally, because that's the thing that is frustrating from a clinician point of view. One thing you hear a lot from is, why did nobody tell me this? There's so many opportunities that we could change that. It's just in that short window that you're actually in antenatal services or postnatal services, it's so short.
Again, it's because there are enough of you, isn't it?
Yeah.
To see, I mean, ideally you would be seeing every woman, whereas often it's only those higher risk ones, isn't most units?
Yeah, what are you doing?
At the moment in Lewisham, we don't see anybody on the wards, we only see outpatient services, but there's potential for spreading our skills, as Elaine mentioned, by training other people, by using digital technology to support sharing our skills with women, with other professionals. So I think there's scope for some very creative plans.
And also, it's not really, once somebody's had a baby, then there's not a sell-by date on seeing physio and having an improvement. It takes an average of 7 years for somebody to come and seek help, if they do at all. And only about a quarter of women will go and speak to their GP about their leaking. So we want to change that. But there's lots of evidence that you can see people 20, 30 years after they've started having a problem, and they will still improve earlier in term.
Sure.
And what percentage of women are estimated to experience symptoms?
It's about 1 in 3 is what the stats say. 1 in 3 women will have some sort of leaking. Having said that, though, the data is almost entirely taken from women who are attending clinic, and women who are in clinic are heavily skewed towards people like me, urban white middle class women. So we actually know very, very little about women in geographically remote areas, culturally diverse areas and economically deprived areas. There's barely any information about these women at all. which is one of the reasons that I did the comedy thing, because I was thinking, how do you get hold of them? You might not want to come into clinic because there's lots of challenges with time and access and who's going to look after the children. But if you can go out into their community where they are and make them laugh about something that is excruciatingly embarrassing, there's so many barriers because people are mortified that they have problems with their continence. There's also quite a lot of it that's funny, like funny things happen. I had a patient, the reason I wrote the show was because I had a patient that was Glaswegian, and she told me a story about her wetting herself in the doorstep, which is a terrible thing to happen to somebody, but she was Glaswegian, so it was really funny. And I said to her, can I use that in doing stand-up? I had a hobby of stand-up, and I think there's something in it, because if you make people laugh together, if they get a joke, they understand that they have a shared experience. And the thing about this stuff is it's so socially isolating. People feel so alone with it, and it's awful. But if you hear somebody laughing at a joke about incontinence pads, you know that they've used the incontinence pads and they understand why it's funny, that particular thing. So it seems to be effective, and we're Galway University are putting in an application to see if we can do some research and see whether humour is an effective health promotion tool, which would be really useful.
Wow.
Fingers crossed. Wellbeing of women can give us some money.
And on a day-to-day basis, what would you recommend to women in terms of pelvic floor exercises? And can you take us through a pelvic floor exercise?
Oh, that's right. It is a problem teaching people how to do it, because if you're trying to fix your big wings or get big guns, usually women have got a pretty good understanding of what their arm is and what it does. But certainly in clinic, we find many women are very disengaged with their pelvic floor and what it's like. So there has been lots of research done to see what the best command is to get somebody to do a proper pelvic floor contraction. We know that about 30% of women, if you tell them to contract their pelvic floor, they bear down as if they're trying to push out a poo instead of pulling up. So the action of your pelvic floor is it squeezes and lifts. So it squeezes your holes shut when you want them to be shut, and then when the muscles contract strongly, they lift up to support all of the organs. And they also have to be able to relax to let pee and poo come out, or to allow penetration if that's what you are interested in. It's almost the weekend. So when you look at what women are doing, if you ask them to do a pelvic floor contraction, often they take a deep breath in and lift their eyebrows up, but there's nothing else happening. So the best command is to imagine that you're holding in a fart. So if you say to somebody to imagine that you're somewhere that you really don't want to embarrass yourself, like maybe this meeting, that would be awful. So, and you can feel something brewing, and you know it's going to escape, and you know it's not going to be pretty. So that action that you do of squeezing your bumhole shut to hold in a fart is you working your pelvic floor. There's lots of other visualizations that work. Imagine that you're lifting your testicles to your spectacles. Works on women. Go figure. I tell people to imagine that you're going to pick up a Malteser, but not with your hands, and that works. But you've got to be quick, or else it melts. And there's lots and lots of different visualizations. If you imagine that you've got a zip fitted from going from the back all the way around to the front, and you're just zipping it forward. There seems to be some evidence that if you tell people to contract their back passage, that they get a better contraction than they do if they're thinking about the front. And you hear lots of women worrying that they can feel at the back but not the front, but vice versa. It doesn't actually matter. All the muscles share the same nerve and they all do the same thing. From a user's point of view, I mean, if you're a surgeon, you need to know a bit more about the anatomy, but from actually getting it to work, if you're feeling it somewhere, it's working everywhere. The important thing though is don't hold your breath when you're doing the exercise, because although we talk about this being a floor, it's not fixed, it moves up and down as you breathe. So if you hold your breath lots, it can get pretty tight and just not able to relax. And that creates similar symptoms to incontinence, in that you can have leaking, but you can also have a lot of pelvic pain. And you work a lot with women with these problems. So if if you have pain when you're doing the exercise, or if you get pelvic pain, we don't really want you doing lots and lots of contractions, because you don't want a muscle getting tighter, and you would need it to be able to relax to let the pain poo out. So the command that you tell people would be to imagine that you're going to hold in this fart, you're going to keep breathing at the same time, and you hold it for a count of 10 seconds. Because there's a reflex inhibition of the urge to pee at the count of 10, so it'll buy you a bit of time if there's a big queue at the toilet. Or if you've got a better lifestyle and you're on an aeroplane and they don't don't unfasten the seatbelt sign, that's a terrifying moment for lots of folk. So a hold for a count of 10, keep breathing, and don't cheat by squeezing your butt cheeks or your thighs together. It's right underneath. It's right here that you would feel it, and it's just a wee movement. Sometimes people are expecting it's going to be a big movement, but it's not. It's just a little bit, and that will work for reducing the urge to go. It'll buy you more time, but it won't help you if you laugh or cough or sneeze, because the muscles also have to do a quick contraction to support the neck of your bladder. Particularly if you go on a trampoline, don't do that. That would be my recommendation. It's nobody over the age of 40 that needs to be in a trampoline. So just save yourself the bother. So the first one's a long hold squeeze for a count of 10, and then you need to do 10 quick flicks that go like that. Oh, I'm going to fart. Oh, it's gone away. Oh, that's going to be horrible. Oh, it's all right, it's gone away. And you do 10 in a row. And you do those 3 times a day, is the evidence. Hold for 10 quick flicks, 3 times a day for 3 months, and then once you're dry, you do it once a day, every day, until you die, or else it'll come back. Particularly, people find that they can manage their symptoms, they become dry, and then they get the cold or hay fever or the flu or something, and they're coughing and sneezing, and it comes back in. So it's really important that women in particular are dealing with their pelvic floor every single day and make it a habit. As I said earlier on, it's the adherence that's the problem, which is why squeezy is such a good thing.
And we've had a question about the antenatal stage and what could be done to give women more information at that point about the exercises that they should be doing and what they can do around minimal pelvic floor health. Ali, have you got any suggestions around that?
We'd be very keen that women were taught pelvic floor exercises by someone who knows about it, like you just did now, from an early stage, ideally still at school. So
Yes.
If girls could be taught that, so pelvic floor awareness. Lots of women that we speak to, I'm sure it's the same for you, don't know what the pelvic floor is. Why would they? So it's just that basic awareness of what it is and what they can do. So ideally even before the antenatal period, but certainly in the antenatal period before they actually have the baby, we'd be very keen that that's a bigger part of the antenatal classes.
Yeah, absolutely. The guidelines, the NICE guidelines, say that the women should be given pelvic floor education in their first antenatal experience, but I agree entirely, because based on a study of myself, at that point I was really only interested in the information about how to get the baby out. Anything else was not on the to-do list. Whereas if you get young girls and boys in school age and teach them the basics of this, then it's just a reminder and being revisited when they're pregnant, well, the girls. And hopefully then they would be, if you teach them when they're young, hopefully then they would be doing the pelvic floor exercises, because it's got an impact on your sexual response, and often young people are particularly interested in that. So if they were better at doing their exercises from a younger age, perhaps then 50% of women over the age of 50 having prolapse. But who knows? It should be part of sex ed.
Yeah, I agree.
And revisited, the PE teachers are ideally placed to deal with this. You could get PE teachers reminding them in classes as part of sport, because we know that about 20% of young women aged 15 to 25 wet themselves when they're jumping or laughing. So that stops them from engaging with sport later on, and that's a massive problem. Looking as an almost complete barrier to sport and activity, and diseases of inactivity are now killing more people than smoking. So we've got to sort this out and get women moving.
And women often seem to think that living with some degree of leaking once they've had children or as they're getting older is the norm. Is there anything that we can do to change that message?
Well, we like the phrase common, never normal. And I think the most important thing that we can do is to talk to other people. So as soon as one person person, here's the message that you can be treated, you can be cured, it's not normal, pass it on to somebody else. The more that people can be open about it, and that's what we try and do in PelvicRoar, is to smash those taboos, then the more people feel able to come forward for treatment.
Because conservative treatment, so if somebody has simple stress incontinence, they're just leaking when they're laughing, coughing or sneezing, 6 sessions of physio is up to an 84% cure rate. So there's really no need for people to be putting up with it if we get them early enough. But because people don't have the language, or they're embarrassed, or they don't realise that it's a problem, they wait and it goes on, and the problem becomes more complicated, and then they'll end up on your list.
Exactly.
Whereas if we could have got them 5 years earlier, they would never have needed to be in the state that they're in needing surgery.
We've just had a comment through that midwives get the ante and postnatal footfall, so they should be involved a great deal, and they should be encouraging women to exercise and strengthen their pelvic floor to possibly reduce risk of problems. So do you work with midwives?
Yeah, and I think that midwives on the whole are pretty well informed about pelvic health and pelvic education. A lot of the pressure that they're under is how much information they have to impart to women at that point, and it's really difficult to put all of the pressure onto them to deliver this information and services, because they've got so much to cover. And there's some really good work going on looking at how they're delivering pelvic health information and how they can make it easier for women to access and engage with. So I'm looking forward to those studies coming out.
Yeah, I concur with that, and I think although midwives do know a lot about it, they've got so much to do. So in the woman's first booking visit, they've got the booking visit when they go, they have to be told everything about the pregnancy and the childbirth, given all the choices. And that's something that, it's really difficult to do everything. Similarly, when a woman's being discharged, they've got feeding, they've got everything to talk about, contraception plans. I think it's quite difficult realistically for midwives to do all of that. No matter how good they might be, it's difficult, challenging, isn't it?
In Scotland we have the baby box scheme, where if somebody has a baby, they can opt into this system where they get a box that's full of everything that the baby would need in the initial stages. And it's a lovely thing, and it's been a huge success. The uptake in Edinburgh is about 85%. So there's about 60,000 births a year in Scotland, and everybody is entitled to have this box, but there's zero pelvic health information in it. So I've been doing some work with the government who are interested in putting a bit of information into the box, because the women get that at about 36 weeks pregnant. So at that stage, it's all very real that this is happening, and they will pick through every single thing that's in the box. So they put together a baby room that says on it, do your exercises, like really sweet to do. But in Scotland now, all the babies are wearing the council uniform, because they've all got on the same, they're all in the same sling, they're all wearing the same little outfits, and it would be a way of accessing everybody in their own time, and they will read what they have in front of them. So fingers crossed.
So is that all about the baby then, the baby box?
Yeah.
Because that's one of the issues we have, isn't it, with the postnatal checks, that it tends to focus a lot on the baby. I want it to be more about the woman as well.
Yeah, we've been having some discussions around that, and again around creative ways that we can manage that situation. And we know there's a lot of information available to women, but women are not receiving that or hearing that or having access to it in a way that's meaningful for them and works. So we're really interested in trying to find the most creative ways that we can educate and inspire women. And Squeeze Out was developed as one of those ways. That was launched 6 years ago and has been extremely popular, because again, technology is where we're at these days for a lot of our activities, and people have their phones with them almost all the time, and so having the information that's there is really useful. There's the Best Beginnings app as well, which is extremely popular, so getting more information in that can be an option. So there's a lot of ways, and we have to be careful not to bombard women with information so they then don't hear it, but get it right, and I don't think we're quite there yet.
We do have physio now in GP practices as first contact practitioners as well. So one of the things that we would really like to see would be specially trained physiotherapists doing a 6-week check to see if they've got rectus diastasis, have they got prolapse, can they work their pelvic floor, do they understand about return to activity, so that they're safe and not going to increase the risk of doing themselves and injury. Because again, if you pick them up early enough, you can solve a lot of the problem, you can head it off at pass. And there's been some work done with group sessions as well, so delivering the information to women as a group seems to be effective too, that then you set up a network of mutual support and they don't feel so isolated, and maybe that's something that we could run as well in the community.
So following on from that, we've had a question that we had submitted earlier on today. So many women I met outline the same issues around lack of interest, time or education from their healthcare professional regarding prolapse diagnosis and lack of clarity about how to get help and what is available and who provides these services. Some women's health physios do not appear to be known by all healthcare professionals, and what can we do to change this?
I think again, we need to spread the word more effectively. We are trying to do that with PelvicRoar. Our professional body has tried to do that as well. And again, it's sharing with people. The problem with pelvic health issues and problems such as incontinence is you don't really want to admit to them. So you're not going to go to a dinner party and say, oh, my incontinence is 50% better this month because I've been seeing a physio. But those are the conversations that we need to have. And Elaine and I know from our own children, between we've got 4 sons, who are teenagers, that actually getting anybody used to this concept can actually be relatively easy. So my children are not at all embarrassed about vaginas and vulvas and incontinence because they've grown up with it, and it's just a normal conversation with them. So we can change society, and we can change it so that we can give women and men the dignity and privacy to discuss their symptoms without the shame and embarrassment. But it's a slow progress.
And in terms of healthcare professionals and raising awareness about the role of women's health physios, is there anything you can suggest, Ellie?
I think working together more, so as we're trying to do now, one voice where we're saying the same thing as each other in terms of professionals. I think it's sometimes just ignorance, you know. I mean, I know a lot more about pelvic floor physiotherapists from working very closely with them in multidisciplinary teams, gynae clinics and obstetric clinics, and I think that's how we work better together, isn't it? So I think more sharing of information and more shared materials and information for women, I think the better.
Yeah. To be fair to medics in particular, so when you look at the amount of training that you get as undergrads, there's not enough time to, I mean, I think it's 10,000 hours of education that you get, and there's about 300 in sexual functions, urology things, gynecology things as undergrads. So you're moving on into a different field from conservative treatment, and it's incumbent on physio as a profession to start being a bit more proactive and getting out to find our colleagues and clinicians as they can come and see what we do. Yeah.
I think it's also working closely with GPs as well, isn't it? To encourage GPs not to refer women directly to see a gynecologist, but to go to the physio first.
So this means more of us.
Yeah. Spread yourself.
And we've just had another question through about SPD and support or lack thereof for that. Are you able to consider backgrounds of SPD?
Yeah, we know that SPD, which we now call pregnancy-related pelvic girdle pain, is a hugely common problem and really incredibly inconvenient. And if you're in pain, your pelvic floor muscles won't work so effectively, you can't function as well, you can't exercise. It has a large impact on your quality of life as a pregnant woman and in the immediate postpartum period. Physiotherapy can be extremely effective for that. Manual therapy can help. Acupuncture is used for some women, exercises, advice, how to alter your activity, support garments. There's a lot that can be done. So again, do seek out a referral to a physiotherapist if at all possible, and they should be able to help you.
And just following on from that, how can we lose the culture that urinary distress, incontinence and pelvic pain isn't inevitable during and after pregnancy?
Yeah, it's a bit of an uphill battle. The myths are very persistent, and one of the things I commonly hear in clinic, you ask somebody how much they leak and you say just the normal amount, and you're like, yeah, it's not normal. Working with the media is really good with that trying to reach people from where they are. There's been a real increased number of newspaper and radio and television articles recently, which is really useful, because once women understand that it's common, it's not normal, and there's help available, then they will be more enabled to come and ask for help. But the whole embarrassment about talking about genitals is a barrier to this. So that's one of the things I think that humour's useful for, because it works its way around the embarrassment if you pitch it properly. So it's not offensive, it's not picking on people, you're not trying to say you are incontinent, you are the problem. It has to be like I do it. That's what I think. Don't pick on people, put the joke on me, and then I become the butt of the joke. What I've learned is it's really important not to ask people questions. In comedy shows, often people don't want to sit in the front row in case they get picked on. So I make it clear at the start of the show, I'm not going to ask you anything at all, and then you give them information. And if you make them laugh, then they talk. And if they talk, they're going to break down barriers and share stories and basically nag each other. If you get groups, socially cohesive groups of women to come to see a comedy show or a talk or something, then they support each other and say, that's you. You need to go to GP. Why have you not been yet? And they encourage each other. So you can get little networks set up quite quickly. Yeah.
We've just had another question through. How helpful is physiotherapy in prolapse management?
That is extremely helpful. So there's the lifestyle measures that we can advise and support you on, so whether that's weight loss, managing bowel function, how to lift, carry, how to adapt to exercise. Then there's pelvic floor exercises and core stability exercise, which are absolutely critical. Then there's a whole host of things. You can see we brought our toys with us, but these are support garments. These are by a company called EVB. These are absolutely fabulous. They have a non-elastic panel front, back and underneath. Very useful for women with prolapse, stress incontinence, rectus, going back to sports and exercise. And then there's some pessaries. These are pelvic pessaries used in the vagina to support prolapse. Anything from the largest, which is what I showed to patients, so they're so alarmed by that, they're not alarmed when I show them the one I like to fit them, to rings, donuts, cubes, Gelhorns. These act like a bra would in the vagina, support and lift everything. They can relieve the symptoms of prolapse. We are hoping they can help prevent prolapse. We don't have solid evidence on that, but I'm sure it will be coming soon. They're very good when you're exercising as well. They can be particularly helpful for women with hypermobility and collagen deficiencies, particularly at the extreme end, such as EDS. And I think that pessaries should be used when you're asymptomatic of prolapse to try and prevent that happening. And I heard it, I must have read it from your show the other day, that if you think you would wear a support bra for doing an exercise, you should probably be wearing a pessary as well. So yes, prolapse is one of my pet loves, and I could wax lyrical about that.
And Myra, you mentioned EDS. We've had a question through from someone with Ehlers-Danlos syndrome, and they say that they've been shocked at the lack of pelvic floor advice around, especially for women like them. Do you feel that word is getting out there about pelvic floor awareness in general? It seems a lot more could be done proactively to support women with EDS and other hypermobility conditions during and after childbirth, and also on an ongoing basis. I'd love to hear your thoughts on gynophysio in particular.
Absolutely. I think if you've got EDS or related conditions, you're very, very high risk of problems such as pelvic organ prolapse, stress incontinence. I think that you should be seeing a pelvic health physio as soon as you're pregnant, ideally before you're pregnant, and do a sort of workup. I think you should be talked through bowel management, lifting, moving, exercise, the support wear, the pessaries, using pessaries preventatively, and be supported throughout your pregnancy because your risk factors are extremely high, and I think there's a lot to do to mitigate that.
And we've had another question through. Have you got any suggestions for women who've gone through surgeries and medical treatments and are now dealing with sexual problems such as painful sex or pelvic pain? Could pelvic physiotherapy help with this? Are there any ways these women could be better supported?
That's one of my pet loves, yeah. A lot of women experience pelvic pain, and it can be triggered off often by traumatic experiences, by surgical procedures that not necessarily a problem in themselves, but for some reason will trigger pelvic pain. And this is a pain that often we can't pin down to any particular thing. So you can have lots of investigations and are told there's nothing there, there's nothing that we can see. But there's a lot that we can do. There's a very holistic approach. We look at everything from sleep, stress, relaxation, mindfulness, diet, good bladder and bowel habits, losing weight if that's a problem, stopping smoking, that can have an impact. Then there's pelvic floor function. As Elaine mentioned earlier, you can have just as many problems if your pelvic floor is overactive as if it's weak. So we will do some down training, some stretches. Yoga stretches can be fabulous for that as well. Sometimes we'll down train and relax the pelvic floor, and then you'll find there's a weakness underneath it, then you have to work it back up again. But the aim is to get your pelvic floor functioning normally and really well for what you need it to do. And there's various things we can do to help with down training and relaxation of the pelvic floor. So we can use manual techniques, we can use acupuncture. I'm not sure I could tolerate that myself, but some people do find that very helpful. We can use, where's the wand? There's the wand. So this is, I've got this one here. This is called an easy wand, which is a sort of medical glass wand which you can use to insert in the vagina, and it's designed to fit in exactly all the nooks and crannies, and you can use that to massage and relax the tissues. We've got some dilators here, these ones at the front here that Kerry's going to pick up. These ones are used particularly after surgical treatment, radiotherapy, helping with stretching the muscles. And then the little floppy ones, you just give that a wave. They're nice and soft, and they're silicone dilators. So for women with sexual dysfunction, unable to tolerate being touched or being penetrated, they can be fabulous for helping get used to the feeling something going inside the vagina, massaging it, etc. And if you've had very traumatic smear experiences and you're worried about going for a smear test, we want to encourage everybody to have a smear test because it's just so critical. Then seeing a physio and doing some work with things like dilators can be one way of helping to make that a more positive experience.
And we've just had another question through about pelvic floor exercises. Will they help with leaking a little after weaning than stress incontinence?
Yes, although sometimes that's more with a bladder dysfunction than plain weakness. So if you're having that, it's a good idea to get it followed up. Sometimes people can get bladder, have a bit of retention of urine. So we would encourage people to be able to relax the pelvic floor properly so that the bladder is emptying itself properly. Sometimes it comes down to strategies of you have your pee and then you sit for 10 and see if there's any more to come out. Sometimes leaning forwards a few times can help as well to just try and squeeze the last bit of it out. But if you're having symptoms like that, don't put up with it. Please come to clinic, and there's lots and lots of things that we can do to help resolve the problem.
And you can complete a bladder diary before you come, which would help give some information and track your bladder habits. And you can download some excellent paper bladder diaries from the Bladder and Bowel Foundation, or there's an electronic bladder diary in Squeezy app as well.
And another question we've had through about prolapse. Woman says she thinks the emotional aspect of having prolapse is not talked about enough, how it can affect a woman's quality of life and her day-to-day activity, level of physical exercise. What can healthcare professionals do to support this emotional aspect of things?
I think the most important aspect of this is to find a professional that you can talk to and you feel confident with. And I think prolapse has two extremes. It has a huge impact, particularly on people's sexual function. They often feel extremely embarrassed, very conscious of it, and yet most partners wouldn't even notice it was there. So it's important to acknowledge how traumatic having a prolapse is. And as Elaine said earlier, the common thing I hear managing prolapse is no one told me this could happen. So changing that and educating women about prolapse in advance of them having them, I think is really important. But on the other side of the fence, a prolapse is also relatively normal. So it's a little bit like getting grey hair and wrinkles. And having a small amount of prolapse following having a baby is something that happens, and I don't think we should be too scared about it either. It doesn't need to stop us doing anything or doing any exercise. And we always say that we treat the symptoms of a prolapse rather than prolapse. So you could be told you've got a grade 1 cyst, for example. If it's not bothering you, as long as you know how to manage it, how to prevent things getting worse, then we don't need to worry about it. We don't need to do anything about it.
And there's some studies that have shown that if you do have a prolapse and you do your pelvic floor exercises, it's not going to cure it, but it will stop it from progressing and getting worse. So you can manage it perfectly effectively for years and years and years.
Sometimes we do need to really show women, don't we? Sometimes, especially if women have waited a long time to come and see us, and then you say, actually, this is not serious, this is about your quality of life, and you don't have to have anything done, you certainly don't have to have an operation. has often quite reduced to women actually.
Yes, yeah. There's a lot of fear around prolapse at the moment, and I think in the States they're now saying that if you've had 2 vaginal deliveries, then they would consider it to be medically normal for you to have a grade 2 prolapse. That it's so common, but as long as you don't get constipated, as long as you aren't overweight, as long as you're trying to avoid exercises, then you can really reduce the risk of it becoming a problem.
We've got one final question that's come through. Do you think there could be greater balance in terms of communicating the risks and benefits of planned vaginal and caesarean birth, both generally and also for women who are requesting a prophylactic caesarean with pelvic floor protection in mind, if they want to reduce the risk of damage, including prolapse, and to avoid mental delivery?
I mean, it's the woman's right to say whether she wants to have a caesarean section or a vaginal delivery. I think we do have more to talk to women about. As you were mentioning, we're just talking more now about vaginal tears, perineal tears than we used to. I think there's more media interest for that now, which I think is really important. And actually, I find if we do talk to women about what might happen in terms of perineal trauma or tears and what we and she can do to try and minimise that risk, often that empowers women to have a better experience.
Yeah, I think there's still a sort of a hangover almost from the days where you didn't mention things in case you fright the first time mums. And when I've looked at a lot of, well, every single book I can find about pregnancy and antenatal care and all the magazine articles, and very, very few of them mention about 3rd and 4th degree tears, so that you're getting problems with anal sphincter function, and about post-delivery prolapse. And I would really like to see that change, because it would reduce the fear and trauma from women. Educated.
Absolutely, and I think it will change. You know, our own survey recently, the Oasis Care Bundle, I don't know if people are familiar, so that was 55,000 women, and we didn't have any negative voices from the women about being told. And I think that was more healthcare professionals in the beginning were saying, no, you better not tell them that, because they'll all be really scared, they'll all want caesarean sections, etc. And actually that wasn't the case. Everybody was really glad to know more about what happened. So that's, that's certainly my experience clinically, but that's also evidence-based by that.
Yeah, really important.
And we've had one final question through about the difference between vulvas and vaginas and how we can get that message out there to women. We're looking at the vulva on the table here.
It is kind of right in front of the camera, isn't it? Yeah, I think that is really, really vital part of sex ed. I meet a lot of women in clinic who are completely ignorant about their own anatomy because nobody's ever told them. And vaginas are, smashing organs, but from a user's point of view, there's not an awful lot of the weight nerve endings up there. So almost all of a woman's sexual function is going to come from her vulva, because that's where all the nerve endings are. People are very confused about it. They don't, particularly younger women, they don't like the word vulva. They will do anything to avoid using. My 15-year-old tells me the correct pronunciation is vulva. I use it far too much at home. But that's just an embarrassing thing, because it makes people think about female sexual function, and as a society we are not comfortable addressing women as being adult beings with an entitlement to having sexual function in the way that men do. So I would get this information into part of sex ed and have young boys and girls educated that the tickly bits are all on the outside, and then that's your vulva, and if somebody's fishing around in there, that's your vagina. Because apart from anything else, if women don't have the language about their own anatomy, they can't communicate if there's a problem with it. And one of the things that the Eva Pool, the charity for female cancers, is very, very keen on, is trying to burst this so that women are perfectly comfortable using the word that is the noun. It shouldn't be embarrassing. There's a big difference between giving women education and ignorance. That they can be educated and modest. They just need the language. And besides which, most men are able to differentiate between their testicles and their penis. And I don't really like men being better at stuff than us. So
we've also been working with some fantastic experts expert patients, including Kath from Australia, who's here with us, even though it's 3 in the morning for her, and Claire from Vulvar Cancer Awareness, Jane Lewis, who works with vaginal atrophy, and Emma, who works with lichen sclerosis. And we've run 3 week-long campaigns as PelvicRoar, and we've sent out mirrors through pelvic health physios. And we want to encourage women that once a month they get the mirror out and they have a look at their vulva. And if they think they won't remember what it looks like, they take a photo of their vulva. So if you know your own vulva, you'll know when something's right with it.
I think that's a great point to end on. We've had lots of comments through about the embarrassment and taboos that still exist around pelvic floor health. So I hope sessions like tonight go some way to breaking down those stigmas. What can members of the public do to support PelvicRoar collaboration?
Follow us on social media. We're on Twitter, Facebook and Instagram. And Elaine is with Gusset's Grippers and I am with Squeezy as well. So follow us, tweet, post it, share it with your friends if you can, and help us to spread the word.
And for women who have concerns about symptoms, what would you suggest that they do?
So social media, I think, is really helpful, and hopefully we'll get more of it out there. But also go and see somebody, talk to a physiotherapist, trying to get access to them.
Fantastic. Well, I hope you've all enjoyed tonight's session. Thank you so much for joining us, and to Myra, Elaine and Ali. And do keep in touch with the Royal College of Obs and Gynae for future news. Thank you. Bye.
Bye. Bye.